Hey guys, today we're going to do a little Zoom meeting so I can get you ready to go for clinical. I'm going to start by showing you Canvas. Our class is 213 for pediatric clinical. If you look under modules, you will see a module called Willis-Knighton Map and New Group Information. This gives you a terrible copy of a map just in case you want to print it out and try to make some sense of it. If you're not familiar with Willis-Knighton South, it is located on Burt Coons, not far from Mansfield Road. Please find Willis-Knighton South before Monday so that you know where to go. The next sheet of paper is the Willis-Knighton Pediatric Information Sheet, and we're going to go over that in detail here in just a minute. Then you have your clinical handbook and some COVID information that Willis-Knighton gave us in case you want to read that. Then you have an important module that is titled Required Weekly Paperwork. Everything in this module is due every week. It tells you that you have to do a history and submit that on every new patient. So that would be at least one per week, but probably two, because hopefully I'll have enough patients where I can give you a new patient the second day, but that is not guaranteed. So for every new patient that you care for, you'll complete this form. Then we have our lab test. You'll collect your labs on the first day, and if you have the same patient the second day, you'll just add any new labs so that you can compare those and trend them. If you have a new patient, then you'll do another sheet on your new patient. Same thing with medication sheets. If you have the same patient both days, all you have to do on the second day is add anything new or anything that has changed. Diagnostic test we'll look at, and that includes things like x-rays, ultrasounds, CAT scans, EKGs, anything extra that does not fall under labs. And then you'll do one care plan per week. You can decide which patient you want to do it on. If you have a good idea on Monday, go ahead and get it done Monday night or start on it so you can bring it to me and discuss it on Tuesday, whatever floats your boat. And then every day you'll fill out a daily reflection, and this also incorporates a type of self-evaluation for me. And then under that, you have some optional material that you may choose to print out and utilize. You may not. All of the things in the required weekly paperwork, I do ask that you print off one copy of each sheet and bring with you to clinical, especially on the first day, so that when I'm talking about something, either in clinical or in post-conference, you are totally clear on what data you're supposed to obtain during the day and what goes where. The reference material, you can decide what you want to print out, and I encourage you to explore each of these tabs as you have time. Then here you have your clinical evaluation tool for pediatrics. I know in your med-surg rotations in the past, they have asked you to do a self-evaluation on your grading tool once a week or at the end of your rotation. Please do not do that for me. All I ask you do is the daily reflection. That will include self-evaluation data on that. I will print your clinical evaluation tool and grade you on a weekly basis. And then finally, we have care plan help with just some different tools that may help you write your care plans. So the first thing that I want to do is look at some of this paperwork. So I have multiple documents. I guess we'll look at this one first. So this is your diagnostic template. Say your patient has a chest x-ray. You will write chest x-ray in this section, type the date. Of course, all of this is typed for submission, but if you bring the template with you to clinical, you can handwrite and take notes on it. And then when you go home, you can type it up to submit it through Canvas. So the test, the type of test, the date that it was performed, and then under the interpretations section, this is where you write in the provider's words what their conclusion or interpretation of that test was. What were the results according to the radiologist or the provider? Then down here in your own words, I want you to tell me what that means to you as a nurse. What does bilateral hazy infiltrates on the chest x-ray mean to you? What were the lung sounds for that patient? Did the symptoms correlate with the x-ray? Were you surprised by this? Did it make perfect sense because you heard crackles in the bases or whatever it may be? This is where you talk to me to help me know that you understand the significance of that diagnostic test. So there are a couple of sections here. If you only have one chest x-ray, then that's all you fill out. If you have multiple tests, then you may have to add multiple pages. So these are just Word documents and you can adjust them and add to them as needed. Now, let me show you the history. So this is the first thing, well, when I think of the paperwork that's required and the first thing that you collect of the day, this would be on the top of the list. This is similar to your patho card, disease process card for MedSurg. I just word it a little bit differently. In this first section, I want you to talk to me about what brought your patient to the hospital in your client's own words or the caregiver's own words, as close as you can get to the story that they told you. When you went in the room and introduced yourself and broke the ice and said, so what happened? What brought you guys to the hospital? How did it get so bad that they thought he needed to be in the hospital? And get them to talk to you and tell you what happened. How did a simple strep throat lead to a hospital admission? How did a spider bite lead to a hospital admission? So here's where you get the story. Down here, I want you to look up the suspected diagnosis or known diagnosis for that patient in your textbook or some other legitimate resource and tell me what it is. If we suspect that the patient has an abscess on the left buttock, then here you're going to talk to me about abscess development in children, the most likely culprits, anything that you can find in your textbook that would help explain in a more academic, from a more academic standpoint of what's going on with the patient. And then the last part of it is very easy. You list the symptoms that a patient with an abscess could have according to your resource: fever, swelling, tenderness, redness, whatever symptoms that the textbook list. And then over here, you're going to list the signs and symptoms that your patient exhibited. And if you take care of this patient when they're better, I don't want to know they don't have any of these symptoms now. Well, obviously they had them at one point or they wouldn't be here. This is a learning tool. So we want to learn about a 2-year-old that presents to the hospital with an abscess that required surgery and admission to the hospital. You've got the story of how it led up to the hospitalization. You've got the pathophys of what's going on. Now I want you to learn that some kids present with these symptoms, but your kid presented with these symptoms at the peak of the illness. You might have to look back in the chart to the day they were admitted and record those symptoms or you may get that information simply by interviewing the family. Remember, it's a learning tool. Okay, so that's the history and pathophys. It's very interesting for me to read those. It helps paint the picture for what's going on with the patient. As you're collecting data, you're going to be in the computer and you're going to look at the lab results from the time they were admitted, this admission, until today. Sometimes the patient just came in that night and there's not any lab results in the chart. On pediatrics, we don't have nearly the medications and the labs that you have on the adult floors, so don't worry. So I've listed the most common labs that we see on pediatrics. Your patient may not have all of these. They may have some of them and additional labs that aren't listed. Add you some rows. Erase the ones they don't have or just leave them blank. I just listed things that I would like to know about because I find them to be pertinent on pediatrics. So you have the date of the test, what were their results. Here you'll list the normal range according to the lab. If it says no range given, then look it up in your lab manual or your textbook. Always include a normal range here. And then here you're going to explain to me what is the significance of, say their white count, this 2-year-old with an abscess on the booty has a white count of 16,000, so it's a little elevated. What is the significance of that? Well, it supports the presence of a bacterial infection. Patient suspected of having an abscess most likely caused by Staphylococcus. So you're telling me that it makes sense to you that their white count is elevated because that correlates with the bacterial infection. If their hemoglobin and hematocrit is within normal range, instead of putting within normal range on these lines, because I already know that, I can see that it's within normal range. What does it mean to you? Are they scheduled for surgery this afternoon? Well, it'd be good to know that their hemoglobin is adequate for oxygen carrying capacity when they get put under anesthesia. You could say no evidence of anemia or bleeding. Say something other than within normal limits. That's kind of a no-brainer and just a waste of ink for you to type that. What do platelets do? In kids, we worry about platelets when we see them too high or too low. It's not the same as with most adults. We're not so much concerned about them clotting. Platelets tend to be elevated with acute inflammatory responses or acute phase illnesses in some children. Some viral infections cause the platelets to drop very low, called idiopathic thrombocytopenia. So, and we're going to learn about these things as we go on, but you have the resources, your textbook, your micro book, and there's a reason we require microbiology. And you have me and you have the staff at the hospital to help us understand the significance of our CBC, especially the differential. I'll talk to you a lot about the differential and what each piece of that means. Pick out the pieces of the chemistry that they were tested for. Each electrolyte can kill you if it gets out of whack. High sodium, low sodium, life-threatening. High potassium, low potassium, life-threatening. If everything's normal, great. Is it normal because they're just that healthy? Or is it normal because they're NPO, but we're keeping it within range through the administration of D5 half normal saline with 20 milliequivalents of KCl per liter at a maintenance rate? What if they have a history of vomiting and diarrhea? Are they at risk for a deficit? in one of these labs, tell me everything you can think of, their diet status, their IV fluid status, their symptoms, their drains, their wounds, their vomiting, their medications. Um, Albuterol causes blood sugar to go up. Many antibiotics can affect the creatinine, and dehydration affects the BUN. Everything you can think of that could pertain to this patient. And you don't just know the stuff from the book of you have to look it up. You have to study. And we don't always have time to do that. We rarely have time to do that in the hospital. We can talk about it, we can question each other about it and point things out. But when you go home, you really start to read about these labs and connect those oh my, excuse me, connect those labs with the symptoms of your patient. If they have a urinalysis, you've got a spot for that. Sed rate and C-reactive protein, both are measures of inflammation within the body. The viral respiratory panel is a very common lab test that we do on these kids, because at least half of them come in with a nasty contagious virus. So it's a nose swab that a lot of the kids get. The panel will come back and it will test for 15 to 20 different viruses, and 1 or 2 might say detected and the rest say not detected. So you would just say which you would say RSV detected or none detected. Just tell me, what was positive. We test for mycoplasma. This is the strep throat test, and there are more. And then I will talk to you more about this in clinical. These are called the fishbone diagrams, and you'll see the physicians fill in the blanks. And if you don't know what the numbers in the diagram stand for, this is your guide for what those numbers stand for. Okay, and then we have our medication sheet. It is very important at the beginning of your shift to take note of the weight of your patient in kilograms. We can't calculate safe dosages on anything without knowing the weight of the patient. So you don't want to come to the med room to give a med with me or your nurse without knowing the patient's weight. Sometimes we get called upon quickly to give a medication, and it would just be really good if you have it jotted down on your notes what your patient's weight is if you don't already have it memorized. You'll list the medication as it is ordered here. You will calculate the safe dose range here like you did in dosage calc. Hopefully you did that for pediatrics. If not, we'll go over in post-conference how to do that. Any side effects that you think are important to know for your patient. You don't have to list every single one in the book. If there are certain things that jump out to you, certain things that you must know, certain things that you would want to educate the family about, you'll just jot those down. And then here, the most important column, the specific reason why the patient is receiving this drug. Do not tell me they are on Bactrim for an infection. I already know that. Why Bactrim for this specific infection? Why not Rocephin? Why not vancomycin? Why not Zithromax? Why did the doctor choose Bactrim? What kind of bacteria or organism is Bactrim going to kill? And why do we think that's appropriate for this patient? That's how you're going to learn your drugs. Seeing it, connecting it with a patient, making it make sense. So that's fun too. And then you have your care plan. And I've given you in the care plan help section an example of a nursing diagnosis. We will always have 2 goals. The first goal is directed towards the patient. The patient will do XYZ. The patient will. Assume a respiratory rate of 12 to 20 without evidence of accessory muscle use by EOS, end of shift today. Okay, first I want to point out, I did not say patient will assume a normal respiratory rate. What's normal? It depends on the age of the patient. So be specific with what kind of respiratory rate you would like to see by the end of your shift. We cannot measure if we've met our goals or not if we put by discharge. That doesn't work for us. We need our goals to be met or not met or partially met by the time we leave. I don't care if the goal was met or not. That's not what's important. The important thing is that you recognize the priority goal for your patient. If you are that patient's nurse, the interventions that are required to help meet that goal, the evidence behind those interventions, and then it's just kind of a FYI, we didn't meet this goal. I mean, duh, they just were admitted last night and they're sick as snot. But hey, we're working in the right direction. I know that you know the appropriate interventions and appropriate goals to help this patient. So you have your goal and you have your target date, which is always that day of clinical. Then you have 3 interventions, always have 3 interventions. And notice I said number 1, goal, and interventions 1A, 2A, 3A. Okay, so in interventions, I look for action words. My action word here, ensure, administration of respiratory treatments. Well, the respiratory therapist does that. Yes, they do. But you, as the registered nurse, are in charge of ensuring those treatments are given in a timely manner and that they are responding to the medications as needed, as appropriate. If the respiratory therapist leaves the floor to go take care of other patients and your patient is wheezing and retracting, can you just say, well, they'll be back and give you another treatment at 4. You hang in there for 2 more hours. That's not okay. You're in charge of that. So it's okay to take on that intervention as your responsibility to make sure they're responding to those drugs. You're going to keep the head of bed greater than 30 degrees to facilitate frequent repositioning. That's a very simple, basic intervention, but it is so important and it is evidence-based. And then assist as needed with CPT, whatever you want to come up with based on, what are we actively doing for your patient? You don't have to just make this stuff up. Go home and think about what was the priority thing that we were doing for my patient today. What was their priority problem? What kind of interventions did we do? Then look in your textbook under that disease process at the types of nursing interventions that are indicated. Oh, hey, we didn't do this intervention, but that would have been a good thing to do. I think next time I'll think about incorporating that and add it to your list. I don't care if you really did it or not. I care that if you had an opportunity to do it, you did or you attempted, and I care that you recognize this would have been good to try, or we would have done this if my patient had been able to tolerate it. Under the rationale, of course, you will find word for word rationale and let me know the resource that you got that from. And then goal number 2 is always an education goal. Patient and or caregiver, whatever's appropriate, will understand the disease process or whatever it is that, and I'll help you with these things. We help each other figure out a good education goal related. Remember, it has to be related to goal number 1, and goal number 1 and goal number 2 have to directly tie back to the nursing diagnosis. Sometimes we think of a great education goal and get off on a tangent down here and then come back and realize, hey, this has nothing to do with this, and we have to start all over again. So it takes a little bit of work, but it can be fun. If you keep it simple, you remember that you're looking for your priorities. Goal number 1 is always about the patient. Goal number 2 is education. Your interventions, I'm always looking for action words. Ensure, maintain, assist. provide, explain, teach, give me action. And then you only evaluate goal number 1. Did you meet it or did you not meet it, or did you partially meet it? And you're going to evaluate goal number 2. You don't evaluate each of your interventions. The interventions are simply a means to meet the goal. And I believe our last thing to look at is our daily reflection here. Very simple. I kind of got it started for you. What went well for you in clinical? Well, I didn't oversleep today. Okay, you can put that if you want to, but don't stop there. Tell me, talk to me here. A lot of you are going to be shy and not want to talk. This is your chance to tell me your thoughts and feelings. Get it all out. What would you do differently? There should always be something you would do differently if you could go back and do it differently. I mean, everybody has that every day of their lives. It doesn't mean that you messed up. It just means that when you went in the room and introduced yourself and, started your assessment on this toddler and they were screaming and on, sometimes when you walk away and you look back, you think, oh my gosh, I could have done what he did, and go hand him my stethoscope and let him play with that and kind of make friends with him before I started my assessment. I got my assessment done, but man, I went through a bunch just to get it done. Next time, I think I'll try this. I mean, maybe you did mess up. This is where you admit it and you recognize, I've got room to grow here. This is what I would do different next time. Today I learned you ought to be able to write a book here. Even if it's something as simple as how to work the side rails on the bed, there are things you are going to learn every day. These sections are all very important because they directly tie to your grading tool. Here you'll tell me 2 developmentally appropriate interactions. Oh, excuse me, y'all, it's 2:30 in the morning. 2 developmentally appropriate interactions that you have with your patient. That means if your patient was 2 years old, what did you do to get on that 2-year-old's level? How did you interact appropriately with the 2-year-old? You can't ignore the 2-year-old and just interact with the parent or the caregiver. You got to connect with that 2-year-old or make every effort to. I gave him my stethoscope to play with before I assessed him. I gave him a sticker. I threw the ball back and forth. I sang Paw Patrol with him. Whatever it was, if it's a teenager, how did you interact with? Well, I talked to her about homecoming and what kind of dress she was wearing. I complimented her on her nails and asked what nail salon she went to. I talked to him about school and asked what he liked to do, if he played any sports, or we talked about duck hunting, or whatever it is that connects you with your patient. Sometimes it's silly stuff, but it's so important. What cultural norms did you assess that could have a positive or negative effect on the child's health? Let's see. Both parents were physicians. They seem very well educated about their child's illness, and the child seemed to have all of his needs met. That's a positive thing, right? Or the room reeked of cigarette smoke. The mother was always on the phone. The parent never came out from under the covers the whole time I was in the room. You can't change the world. I just want you to recognize everyone's not like you, but that's still the kid's family. You've got to recognize cultural norms so that you are able to relate to that family on their level, to educate and to be an example, because it's not about you, it's about the kid. If we don't connect with these families, the child suffers. We are not there to cast judgment, but we have to recognize what we're dealing with. List a thoughtful intervention you did for the family. That's not following an order. That's, hey, can I go get you a cup of coffee? Or would you like me to sit with your child so you can go take a shower? Or did you not like what they brought you on your lunch tray? And let me ask if I can get you something else. Or do you need an extra pillow? Let me see if I can go find one. Just maybe you just listened and the mom had a crying meltdown. And since you were a student and only had one patient, you spent an extra 10 minutes in the room just listening to mom and being supportive. And then any education that you provided. Every day you will provide education. At the beginning, it may be remember to put the side rails up all the way, or um, let's see, side rails, the IV, show them how you assess for IV infiltration and say, let me know if the baby gets fussy and you don't know what's wrong. It could be that the IV is starting to hurt him. If you notice the fingers getting puffy or the hand getting cold, let me know. Kind of as you do your assessment, the family is just begging for information. They're shut up behind those doors all day long, just waiting for someone to come in there and tell them something. On that note, be very careful that you don't overstep your education role. Just if it's anything that you are uncomfortable saying, you make sure that you okay that with myself and the nurse. There's a lot of educational materials that we can print out for the families, but you don't ever want to give them anything without talking to me or your nurse beforehand. And that's it. So you do one of those every day. And then we will look at the grading tool in post-conference. Okay, so we did that. There is one other thing that I want to talk to you about, and that is the student information sheet. We've already gone over a lot of it, but let's just see what I might have missed that pertains to showing up on Monday. My cell phone number is on your syllabus as well as on this information sheet. Please put it in your phone. And text me if you are running late, if you have a sick child and you need to give your husband or your wife my cell phone number, or your babysitter or your mother-in-law, give it to them, because you cannot have a cell phone in clinical. You have to leave it in your car. So that includes smartwatches. You can't have it. Your syllabus says give your significant others Miss Turley's number, Miss Cindy's number. I'm telling you, give them my number. I will have my phone on me at all times. They can call me, text me. I will let you use my phone if need be. I will relay messages. It will be okay. If you have a flat tire or you're sick or something's going on, please call or text me no later than 6 a.m. If you oversleep, of course, that it doesn't work out so well, but just as soon as possible, let me know what's going on so that I can give you some guidance. I gave you a blurb here about parking. We park in the parking garage on the very top floor. If you do not park on the 4th floor, the police will meet you as soon as you get off the elevator. I'm telling you, they have nothing else to do there but monitor where nursing students park. So please park at the very top. And then you're going to make your way to the 3rd floor, cut across all the way through the clinic building. I gave you specific instructions here till you get to the main elevators. Take the main elevators to the 1st floor. And here I talked to you about the procedure of having your temperature checked and receiving your mask. So read all of this about how that's going to work. And then we will all meet up right there in the atrium, and we will go upstairs together. Once I show you the way, for the next couple of days, you will go through this process on your own. The first day I'll be there with you. the next couple of days, I will be there before you, and I'll be upstairs making assignments, and you just come on up to the second floor to the pediatric waiting area. There are lots of chairs, and you just sit there and wait on me to come out and give you your assignment. I gave you the phone number to the unit in case you can't get a hold of me. So my phone is on silent some of the time, so I may not feel it vibrate. If you're panicking, feel free to call this number to the unit. So you're going to wait there, and I'm going to give you a brief report on your patient, and then you're going to go into the unit, find which nurse is assigned to your patient, and listen to report from the night shift. Meet your nurse, introduce yourself, talk about your role for the day. And then I go on to kind of give you a rundown of an ideal day. It does not always work this way, but I have to start somewhere, right? Ideally, you get report, you go get vital signs on your patient, record your vital signs, make sure if anything's not within normal limits that you tell your nurse and you tell your instructor. If your patient's awake, you introduce yourself to the family, have a little get to know session, do a quick life threat assessment. You're assessing for life threats, for pain, respiratory distress. If they're on oxygen, make sure it's properly, in place. Make sure their IV is not infiltrated. Just do a quick look over to make sure they're alive and well, because at this point, the night shift has left and you are legally in charge of the well-being of this patient, and you have to document at 06:55 you laid eyes on that patient, or whatever time it is that you get in there, you laid eyes on that patient and made sure they were okay. You tell them you will be back soon to do a complete assessment. Okay? You don't have to finish your assessment the very first time you see them, but you have to see them and make sure they're okay as soon as possible. We help pass out breakfast and lunch trays whenever they get here. After you do that quick assessment, you come out and you go through your charts and your MAR, and you kind of get a plan for the day. You make sure there's not anything crazy in their lab values or pertinent orders that need to be followed immediately. Kind of read through the chart to get to know your patient, write down their weight, allergies, and all of that. And by 9 o'clock, once you've spent some time gathering some data and getting a grasp of your patient for that day, you need to go back in there and complete your head to toe assessment. Some of it you already got done. If it hasn't changed, just, take note of what you have left to do. Try to get that knocked out by 9 o'clock. And if you think about it, if you're in charge of this patient and technically you clocked in at 6:23, by 9 o'clock, surely you've assessed your patient. So we don't have much time to make a nurse out of you. We have 3 semesters. So you're going to push and challenge yourself to get it done and do it well. Every day getting better and better and better. The rest of the time after that head to toe is done, you're doing a variety of things. If you have meds to give, you're giving meds, you're collecting more data from your chart and your computer, all that stuff that has to be filled out on the papers. When the doctor is at the bedside, you need to be at the bedside. So I help point out, okay, Dr. Chu's here, this doctor's here, that doctor's here. If you have a surgery patient, the surgeons are on the floor and you just stalk them. And when they go in your patient's room, you go in too and stand like a fly on the wall, and you listen and learn. You don't talk unless they ask you a question. You don't offer information unless they ask it of you, okay? Don't ever interrupt or speak over a physician or a nurse practitioner. That belittles them in front of the family. I encourage you, when you leave the patient's room, to ask the physician or the nurse practitioner or whoever it may be your questions and have a discussion with them about the patient if they seem willing to do so. Just don't do it in front of the patient. So we don't do baths on our kids because that's a lot of the kids came in the middle of the night and they're exhausted. The families are exhausted and they're children. They don't want a stranger coming in and looking at their private parts, okay? They're not in ICU, sedated and on a ventilator. It's different there. This is the floor. This is a very stressful time for the families. What we do is recognize when they're filthy. If the mom's asleep, we clean them up. If the family's awake, we say, hey, look at all these Cheerios and crumbs in the bed. I tell you what, I'm going to bring you some new sheets. Mama, when you have a minute to hold him or put him on the couch with you, I'll change these sheets for you real quick. Do you want to give him a little bed bath? Do you have some baby shampoo in here? Do you have some washcloths, some towels? Let me go get stuff that you need and I'll bring it to you and you let me know if you need any help. Let mom give them a bath. That's her job or dad's job. You know, we're there to help if they need our help, and we're there to provide their supplies to encourage cleanliness, and we make sure that everything's clean before we leave our shift. But we're not going to force a bath on a child in most situations. Between 11 and 12, it's time to do vital signs again, and we do a focused reassessment. If they're there for a respiratory problem, our focused reassessment is on the respiratory system. And then we usually skip lunch and we just go straight on into post-conference. You can bring a snack if that sounds awful to you, but usually I've actually never had a clinical group that wanted to waste 30 minutes in the cafeteria. By the time the clinical day was wrapping up, they were ready to go to post-conference and get the heck out of there. So if that's okay with y'all, that's what we'll continue to do. Do not bring large bags. Just bring a folder with your, or a clipboard if you have the kind that stores papers, to keep your necessary paperwork in. There is a break room that we can put lunch boxes in. I just can't promise there's room in the refrigerator. Make sure you bring a calculator and whatever clinical supplies you need in your pockets. Bring your stethoscope, of course, some scissors. A couple of you can bring a drug guide, and we will leave those on the counter at the nurse's station. Make sure you write your name in it, and then all the students can share those drug guides. Do not bring drug cards to this rotation. I don't want them. Don't bring blood pressure cuffs. Don't bring big care plan books or textbooks. That's stuff you're going to do at the house. Make sure your tats are covered, your hair is pulled back. No jewelry, no necklaces, just a watch and earring studs. Make sure your BIPSI badge is not the first badge showing. Your Willis Knighton badge has to be visible. And let's have fun. It'll be great. We have there's a lot. I know it's a lot. What I'm also going to do is post my physical assessment PowerPoint for you. I'm going to post that under this module, this course, so that you can look through it. Let me show you an example because I know you're sick of me talking, but I'm going to show you an example of what I'm talking about here. I have shown our kids on the pediatric floor oftentimes are on cardiac monitors that are mounted to the wall. We're going to be looking at things like their heart rate and respiratory rate and pulse ox waveforms and things like that. So that's why I have this on here. This is the oral axillary thermometer that we use on peds. The last time I was there, we were not using temporal thermometers anymore. The physicians didn't care for them. So our main thermometer is this oral axillary thermometer. Occasionally we use the tympanic thermometer, but I think that was broke too, unless they've got a new one. And then there are always the basic digital thermometers that we use for patients on isolation precautions and things like that. We do not do rectal temperatures on any child on pediatrics. That is considered invasive. A rectal temperature is not done without a physician's order. There are multiple sizes for blood pressure cuffs. Basically, for infants, we have the green cuff, and then for child, we have light blue. and then for small adult, the dark blue. The best place to take a blood pressure is the right upper extremity, but you'll see them taken on the lower extremities as well, just because it's easier to get to that part of the body. But if you get a number that does not make sense, we've got to redo it. We've got to report and record legitimate vital signs, or we've tortured the child for nothing. So come get help if you need help. Pulse ox probes, we have multiple places we can put those on the children. Every child gets a pulse oximetry reading every 4 hours, and many are on continuous pulse ox. It can go, here you can see how the pulse ox, the little red light, is over the pulse in the foot. It can go over the toe, the fingernail, the wrist. There are many places we can go, but most importantly, we want to see that good waveform to know that it's accurate, and we have to educate the families that when the child moves their extremity and that waveform goes away and the alarm starts to beep, don't panic, because it's not accurate, because the child is moving. Here we have neonatal electrodes, white on right, smoke over fire. White on right, smoke over fire. White, black, red. White on right, smoke over fire. Here we have the pain scale. We use the Flack scale a lot on PEDS, and then we also use the Wong-Baker-Faces scale. You will need to get pain assessments on your kids as part of your head to toe assessment, and with different interventions, and we'll talk about that more. Sometimes we have to do daily weights on our patients, every 12-hour weights, every new admission we have to weigh. So you will get experience with these infant scales, hopefully. And this is an example of a diaper scale. If you have a baby on strict eyes and nose that wears a diaper, 1 gram of diaper weight, 1 gram is equivalent to 1 milliliter of urine. So we zero out a dry diaper, and then we put the wet diaper on the scale. And if it weighs 30 grams, we record 30 milliliters of urine output. When we do new admissions, we get a head circumference and an abdominal circumference, as well as a length on the patient. The head circumference is for all children less than 2 years old. Any child less than 2 years old gets a head circumference. And then there's just some other assessment tidbits here, and I just hate that you haven't had this class yet, and we will have it in detail eventually, but I'm going to give you a head start. I'm going to post this for you, so just look at it under one of the modules on Canvas. And I will see you guys on Monday. Everyone, please watch the video, and I'll see you in the atrium at 6:30 on Monday.